What do you want to do?
Good afternoon, everybody. We're going to start in a little bit. If everybody can get a seat, that'll be great. Well, welcome back, everyone. I hope you had a great lunch. It was actually really good. Hopefully you all not fall asleep right now. Okay. We're going to get our next session started from basic to clinical translation in pancreatic disease. I have the pleasure today of moderating. I am Sobeida Cruz Monserrate. I'm an associate professor at The Ohio State University, and I'm co-moderating this session with.
My name is Fred Gorlick, and I'm on the faculty at Yale University. And I get to co-moderate this session with Zobita, as we often do. So I think without further ado, I saw him come in the
Yeah, it's
room.
right there.
He's still here. He's still here. It's my great pleasure to introduce my very long-term colleague, Dr. Ashok Saluja. Ashok is a professor at the University of Miami and heads a internationally known research laboratory that investigates both pancreatitis and pancreatic cancer. The session, Ashok's presentation and the rest of the sessions today, I think are going to ask some very important questions, and that is about how we model disease experimentally. And it's certainly a question I get when my grants are reviewed and they look at my models. So we appreciate the input from all three speakers today. Our final speaker today, unfortunately, could not make it. That'll give us a little more time for discussion. We're going to hold our questions until the end. All three speakers have presented, have them come up. Dr. Saluja, welcome.
You are glad now because after my talk, you might think, why did we invite this guy? But so thank you. Actually, again, thanks APA and thanks Fred and Javeda for inviting me and giving this talk. I must apologize to start with that I had a big lunch and I'm very badly jet lagged. So it's a bad combination to be that. So I apologize for all the goofs I'm going to make. So anyway, so I've been asked to discuss translating from mouse to human in pancreatic diseases. And I added this, that why we fail. Actually, reality is that most of the time, our animal studies don't pan out. I'll give you several examples, and I'll give you at least my take that why things don't work. And what we are doing wrong or what nature is wrong, and maybe how we can fix some of the things. This is not easy to fix some of these things. So we'll start with that. Unfortunately, we have a little more time, so I'm going to take more than 12 minutes. So can I have my, I did. I think the same issue as we had before. Okay, good. My disclosure, we'll move on. So the goal is to study mechanisms and use the animal models. Eventually, the goal is really to find treatment and treatments, cures for pancreatic disease, both cancer and pancreatitis. Obviously, our goal is to take care of human disease, not mouse disease. It would be nice if we had human pancreatic tissue. Unfortunately, that's mostly not possible, particularly during disease initiation, impossible. You have a mild pancreatitis, who's going to give you your pancreas, right? So that's not going to happen. Same thing is during active injury. Dr. Gorlick's of the world wants to treat it, not the pancreas out. So that's not going to happen. In the last stage, at the end stage, we might have some excess of tissue, but that's really not much useful. By that time, it has degraded and all kind of other issues, everything, and has been treated so heavily by that time that is really of not much use. So what do we fall back? We fall back on, mice, right? So these are the animal models. They are the ones which are available to us at any stage we want. Too bad for them and good for us, right? So mouse is really a preferred tool for medical research. Obviously, all of us know some of the reasons. There's significant, not complete, we'll come back to that, genetic homology between humans and mice. It's very easy to manipulate genetics in mice. We have all kind of knock in, knock out, CRISPR and this and that. So it makes it easier. Size is small, even I can handle it, or at least used to handle it in my good old days. Inexpensive, relatively inexpensive. The breeding is very rapid. Compare that with human breeding versus mice, and you can double the size of your colony in 2 months, 3 months. In humans, it will be 3 generations if everyone works very hard. And so that's not going to happen. And ease of handling. So all of these are good things. So while many of these animal experiments predict disease, human disease outcome reaction, others don't. I'll give you a couple of examples here. For example, penicillin was observed to protect both mice and human from staphylococcus infections. Whereas isotretinoin, which is actine, caused birth defects in rabbits and monkeys as well as in humans, although not in mice and rats. Now, go other way around. By contrast, corticosteroids are widely teratogenic because birth defects in animals, but not in humans. We take a lot of steroids. Whereas thalidomide is not a teratogen in many animal species, but it is in human. So there are, some similarities, some animals have provided useful information over the years. Environment and genetic manipulation is easy in mice, as we discussed. Preliminary testing in mice obviates the need to test new treatments in humans. And that's very important. I mean, I'm going to be very critical of, mouse studies, as you will see. But at the same time, they are very, very essential. While 90% of studies in mice which pans out and we can cure does not work in humans, maybe more than 90%. But at the same time, if something does not work in mice, if your new therapy does not work in mice, probability is 99.9% it won't see a human patient. It will never happen. So these are important studies to do, although there are problems. Regulatory authorities, and I know personally that FDA, for example, or any other thing, they will not accept any of your clinical trials unless you have a strong data from animals, both toxicity and efficacy. So lastly, the animal studies render insight into pathophysiology and etiology of disease and often reveal novel mechanistic insights which can result in therapeutics. Despite all these advantages which I talked about, most animal models do not accurately predict outcome in humans. So, because mouse and humans are very different organisms, I don't have to convince you. Humans are roughly 2,500 times larger in size. Metabolic rate in mice is 7 times more than a human being. Our diet, microbiome, pathogens are very different in mice and humans. Inbreeding and domestication of mice. Most every mice is inbred, so whereas humans are not, and there are big immunological differences. So all of these are big differences. Okay. And I can't even read because of that. So anyway, strategies associated with some of the animal studies. So there are genetics and biological difference between mice and humans. Therapeutic efficacy in animals often does not translate in clinical domains. We'll talk a little bit more about that. Animal models do not adequately mimic human pathophysiology. I'll give you some example. Test animals, actually that's very important. Test animals rarely have comorbidities and are not exposed to range of competing and interacting interventions that humans often receive. I mean, when you have a pancreatitis, you have a pancreatic cancer, you are already having 20 other things before you get drug of your, which you want to test. So whereas in mice, there's nothing. You just give your drug, they are naive, they haven't seen anything, they were just born. So that's a big difference. The timing, route, and formulation of intervention may also introduce problems. So animal studies have not adequately contributed towards translating to human pancreatic disease and are not many times mechanistically driven. I'll give you, so what I'm going to do is I'm going to take mostly, I'm going to be critical of many studies which have done over the years in mice, both in pancreatitis and cancer, but I'm going to use examples from my own study so that I don't offend others that they have done something wrong. I think it's only fair. So role of trypsinogen activation during disease onset. I think many people, if not all of you, know that we have spent significant part of my life studying early events in pancreatitis, right? So all of us know that the first thing, the calcium goes up and calcium is bad in acinar cells. That results in trypsin activation, whether it's cathepsin or not. Marcus is not here. We can argue about that. So there are a lot. But these are the events, and not only me, like half the people in this room, including Julia Meyerly and more so Dr. Sihintot, who's not paying any attention, that he has spent lot of effort, in studying trypsinogen activation. But my friends, that happened in animal studies in first 10, 20, 30 minutes. Whereas pancreatitis evolves over time. You don't see a patient of pancreatitis in first 30 minutes or 1 hour or 2 hours or even in 1 day or 2 days. Most of them have a little pain, they take some Tylenol, whatever, Darwin will recommend. And if it doesn't get better, they come. By that time, calcium, trypsin, magnesium, everything is done. We don't have to worry about those things. And lo and behold, we have trials that how to prevent inhibition of trypsin, how to, prevent calcium increase and how to do this. I don't know what we're going to find with those things. The disease is already there. So those are some of the problems we have, the way we have conducted studies. Okay, how about the other thing which the field has struggled, role of CCK, cholecystokinin. I mean, in every study in mice and every other animal, you can study role of CCK. For example, here's the data which when I used to be young at one time and work in the lab, and we did these experiments where you can see that in mouse you give CCK or cerulean, same thing. There's a robust secretion of amylase, all digested inside. You take human acinides, there's nothing. So not only they don't secrete, human acinides, as shown in this, don't even have CCK receptors. As a control, we have a human gallbladder, which has very robust receptors. Mouse SNIs have a lot of CCK receptors, but nothing in that. We have done, PCR and all those kind of things, the results are same. So the fact is there are no CCK receptor. So studying the effects of CCK agonist, antagonist, and on in human disease, I mean, I don't know where we are going with those things, right? So, and I have done the same thing. So I'm critical of my own things, but others are at the same boat. So animal studies have not adequately contributed towards translating human pancreatic diseases and are not mechanistic reason. Actually, the last example I want to take is very interesting. And most of you, because you are very young, right, you might remember, there was a trial on somatostatin. There was a company, I think they were in New Jersey, Sandoz, and they call it Sandostatin. And they had a clinical trial in pancreatitis patients without doing any preclinical studies with somatostatin. Somatostatin inhibits excretion from S nerve cells. And this is a known fact, whether, we can agree and disagree with trypsin and what, but the fact is that during pancreatitis, secretion, digestive enzyme secretion is blocked. And here is a drug which further blocks secretion rather than increasing the secretion. So what will happen? Obviously, the outcome was bad. People got sicker with, sandostatin rather than getting better, and they have to stop the trial just in a few months. So these are the things when you don't pay attention to mechanistic studies, you can't, make a difference in this. So what are the challenges associated with models used in studying pancreatic diseases? Okay, all of us have studied pancreatitis. So what are the models? Cerulean model, CDE diet model, arginine, duct obstruction, duct infusion. And I think Dr. Meyerly has done some very interesting new models and this and that. So the question is, these models, which I have spent lifetime, and so are many, they do help. We learned pathophysiology. We learned the role of calcium and trypsin and NF-kappa B and on and on and on. Good, we needed that. But what is there relevant to the disease? When was the last time you had a patient who says, I got pancreatitis because I took too much cerulean, I ate like a whole jar of arginine? It's not going to happen. So what is the real relevance of these models, which I have spent lifetime doing it, right? So just take that in stride. So we have to come up with models which are true representation of what the etiology of the disease is, not because it's convenient to give every hour cerulean for 10 hours or 3 days or 5 days. How about cancer studies? As Fred mentioned, I've done a few things in cancer. And here is one of my, probably, prime finding. That's what I think. So we have discovered Menalite, for which we had a patent and there's a company, and that was my disclosure, right? So Menalite really, in our mouse studies, this is the orthotopic mouse pancreatic cancer model. You can see here, it's really amazing. I mean, there's 100% protection when you give Menalite, and non-control all mice die in 40 days and Menalite lives. And there are many, many different ways of doing this. And we have done all of that and published many papers. This was from Science Translation Medicine. Now, then we took this to clinical studies. And we were fortunate that we had some responses, nothing like 100%. But maybe 20, 30% response, which was, we really felt good. And actually we are taking this drug further to phase 2 trials. So we are happy on that, but it's nothing like what we found in mice. And whereas compared to what happened in real patients. So what are the challenges in pancreatic cancer models? It's the model problem again. So look at that. What are the models? First thing we do is take these cell lines, human pancreatic cancer cell lines, and which are there for decades, 20, 30, 50 years. By now, most of them are genetically mutated. We still use them. We don't even know what they are, right? Most the models, I think the most common model used to be, and it still is, that you give these cells, inject them in their limbs. I mean, subcutaneous models. When was the last time we had a pancreatic cancer patient where the tumor was in their limbs? It does not happen. But that's the model because it's very easy to, and these models have no stroma, no metastasis, no nothing. Whereas pancreatic cancer, the main problem is stroma. I mean, look at this picture. 80% of the cancer is stroma. It's about 20%, which is epithelial cells. Immune response is very important. Metastasis is important. Nothing happens in these. What are the other models? Orthotopic model using anthemic models that lack immune system. Again, there's no immune system. How can you compare that with patient? How can you take that? One of the most recent and well-used thought of model is genetically engineered KPC mice and some other ones. These are technically challenging, inconsistent time of disease onset, anywhere between 2 months to 10 months. Some mice will have a cancer in 2, some will have 10. Not very useful for translational studies. They're good for mechanistic studies. So therefore, the information generated from these models is not very easy to translate. Translating associated with human studies. Most phase 1 trials, and this is very important to understand, most phase 1 trials are conducted in patients who have failed standard of care treatment regimen, whereas most experiments which we performed in laboratory are done in naive mice. They have no prior treatment history. How can you compare those? The patients are resistant already to drugs, and your mice are not, and how you extrapolate that data? So no wonder 80–90% of phase 1 clinical trial fail. Other problems. Most laboratory studies in pancreatitis and pancreatic cancer used to be and still are prophylactic. That's not going to help us. You don't see a patient that they're going to get pancreatitis next week. They already have pancreatitis. They already have cancer. So again, I'm going to be critical to our studies. Same thing has been done by hundreds and thousands of other people, but I'm going to take our gastroenterology paper 3 years back, where we study gut microbiota. So what did we do in this study? We took the mice, gave them antibiotics for 3 weeks, depleted all their microbiome, injected tumors in them, and showed that they have less tumor compared to the one where we have full microbiome. Everyone has done that. It's not us. And we showed that obviously this thing is very effective. It works well. Great. But question is, can we do the same thing? I'm not sure it's going to work when you have a patient that has pancreatic cancer for the last 6 months, and then you come, okay, so I'm going to deplete your microbiome and see what happens. Maybe it would work, maybe not. But we have to think about these things when we do and publish. Just one more minute. So are we conducting mouse models? Are we using the correct model? And this is really, I'm very, very concerned about this slide. If you didn't pay attention to anything else, which is fine, but just think about this. The mice we use for our studies are 6 weeks old. 6-week-old mice is equivalent to 10 years of human being. Tell me how many human beings you have seen who are 10-year-old and have pancreatic cancer? There are some, I know some. 1 or 2 out of 60,000 every year, or 250,000 every year. Pancreatitis, I know I have a lot of friends here who are pediatric pancreatitis people, and they will claim they have, but still, 10-year-old, 3% of the total pancreatitis cases. So how can we compare results from 10-year-old equivalent of 10-year-old mice to 69-year-old human being who's going to get pancreatic cancer. What else? Most cancer studies are done in female mice. You know why? Because they are docile, easy to handle. You can put 5 in a cage. They don't fight with each other, unlike Fred and I do. So it's convenient and easier. Except there are more males get pancreatic cancer than more men get pancreatic cancer than women do. So we need to think about these things. Similarly, we need to have models where we look at racial disparity. We know that there's a racial disparity in pancreatitis and pancreatic cancer. We have no models to study that. No, zero. So I think we have these problems too. So the proper study of mankind is meant. Just one last slide. So if you want to study, we study man. So what's the path forward? Execute studies in human tissue and organoid, use humanized mice, trials based on mechanistic studies that are more therapeutic in nature and not merely prophylactic. Better study design, better animal models, which more closely resemble human condition disease rather than give arginine and cerulean to mice. And very last slide in conclusion. I wish humans were more wise so that we have cured the disease by now. Thank you so much.
Thank you, Dr. Salusha. We're going to hold questions till the end.
Sorry,
Yeah.
I took longer.
Our next speaker, Dr. Andra G. Hopefully I pronounced that right. Research assistant professor in the Department of Molecular and Cellular Biology at Boston University. So with this one. Yeah, just do this one.
Thank you very much for the introduction, and thank you so much also for the invitation. I felt very honored at first when I was given this task to give a presentation on genetic preclinical model, but right now I feel a little bit differently after Dr. Saluja's presentation. I hope I can still prove that it is very important to develop genetic preclinical models for pancreatitis mouse models in particular. So we all know that acute or pancreatitis is a disease continuum, and it starts with acute pancreatitis episodes, and then it can progress into recurrent acute pancreatitis, which can progress into chronic pancreatitis. And the progression is often driven by genetic risk factors. Genetic risks are overlapping in recurrent acute and chronic pancreatitis cases, but it is a bit difficult to interpret the genetic background of acute pancreatitis due to the often inadequate follow-up, which would exclude chronic pancreatitis and recurrent acute pancreatitis cases. So the different genetic factors have been classified into different pathways, and one of them would be the trypsin-dependent pathway, and today I'd like to focus on this particular pathomechanism in my talk. Why trypsin? Because trypsin was assigned to play a key role in initiating the disease by triggering an activation cascade within the pancreas, and it can also activate itself in a process termed autoactivation, and this may facilitate digestive zymogen activation in the duodenum, but it can also happen within the pancreas, then it leads to the disease development. And gain of function mutations have been identified in the human cationic trypsinogen gene, which is the PRSS1 gene, in association with pancreatitis. There are protective mechanisms working against this harmful trypsin activation, and one would be inhibition by SPINK1, and then the other one would be degradation by chymotrypsin C. Consequently, loss of function mutations have been identified in these genes in association with the disease. Chymotrypsin C actually has a dual role. It can facilitate the activation of trypsinogen, but it can also, but the main role of chymotrypsin C is the degradation of trypsinogen. Again, trypsin mutations have been identified blocking these pathway or blocking the degradatory function of chymotrypsin C, and some of the trypsin mutation would enhance further chymotrypsin C mediated activation of trypsinogen. But a subset of mutation works independently of chymotrypsin C. These are very rare mutations. They are located in the trypsinogen activation peptide, and they have a very robust phenotype, which is the common phenotypic change they cause is an increased propensity for autoactivation. So I'm going to start with these mutations because these are very good candidates for mouse model generation. But just to have an outline of what can we discuss under, or what models we can discuss under the trypsin-dependent pathway. So there are a few which would affect autoactivation or facilitate autoactivation, and we developed a couple of models to study this mechanism. There are a few developed by Boenji and his group targeting trypsin activation by elevating trypsin expression in the pancreas. We can also develop, or we also develop models to study chymotrypsin mediated protection. And lastly, we can study trypsin inhibition in the in vivo setting by developing mouse models for SPINK1. And so focusing on the first one, so like I mentioned that there are these trypsin activation peptide mutation, which were found in association with hereditary chronic pancreatitis. So we started to pick a few of these mutations and started to model this in the mouse. And so far we developed 3. And so these, what they do is that they increase trypsinogen autoactivation. So the D23A mutation causes a 50-fold increase in autoactivation. It's a kind of a homologous mutation what have been found in the human situation, but there is one which definitely mimics the human situation. That's the K24R mutation that causes like a 5-fold increase in trypsinogen autoactivation, and we generated something in between which causes a 15-fold increase in autoactivation. And on the next slide, you can see what this actually causes in the in vivo setting. So what we noticed that in case of the mutation, which causes a 50-fold increase, 50, in autoactivation in the in vitro, we found that this mouse developed acute pancreatitis spontaneously at a very early age, and then it progressed very quickly to chronic pancreatitis. And I'm not a clinician, but just looking at the hematoxylin and iosine stain pictures, I do believe that this mimics the human phenotype. So we also have this mouse which have 5-fold increase in trypsinogen autoactivation. And it's interesting that this particular mouse does not develop pancreatitis spontaneously, but once we challenge the animal with cerulean injection, they do develop more severe pancreatitis than the Y-type control mouse. And then what's even more interesting is that they actually progress to chronic pancreatitis spontaneously, while a Black 6 mouse will just simply recover within a couple of days. And then we have this in-between model, which delays pancreatitis, spontaneous pancreatitis development. So we can clearly see a correlation between the extent of trypsinogen autoactivation and disease onset and severity. And these are very good models to study the pathomechanisms, and not only that, but also to test therapeutics. So we are not alone with the field, in the field, as I mentioned earlier, that Boenji also worked on this problem from a different angle. What he did was to develop transgenic mouse models, where he actually introduced human PRSS1 along with or without the very common R122H mutation. And what he found that when he tested this genetically modified mouse in different types of pancreatitis model, cerulean-induced, ethanol-induced, and high-fat diet, that this mutation and the transgene actually sensitize the pancreas to injury. So he went further and he started to test the effect of therapeutics, protease inhibitors, in particular dabigatran. And he also checked what happens if he not only introduces the mutation and the PRSS1 gene into the mouse, but he adds another isoform, and that would be the PRSS2. So this is what he got, that the R122H mutant mouse had a more severe pancreatitis when challenged with cerulean. Again, what he saw was very similar to what we've seen in our case, that these guys could not recover after an episode of acute pancreatitis. They developed chronic pancreatitis spontaneously. And if he added, or if once they added PRSS2 to the bulk, they actually saw spontaneous pancreatitis development. So again, we can argue which one is better. This one is great also, especially that it carries the human gene. And again, it's an amazing, or these are amazing models to study pathomechanism and test therapeutics. So going further, we also felt the need to look at the role of chymotrypsin in vivo. And what we did is, because in the mouse, there's a little bit of a difference on the role of chymotrypsin C, while in a human, it has a degradatory function. In a mouse, it prevents autoactivation from happening, or it inhibits autoactivation. And so we wanted to generate a chymotrypsin C knockout mouse to study this problem, but we quickly realized that the Black 6 mouse, what we are using a lot, is a natural knockout for chymotrypsin C. So basically what we did is to generate a control mouse. So we restored the chymotrypsin C gene in the Black 6 background and looked at pancreatitis severity. And in a mouse, chymotrypsin B1 is actually the main chymotrypsin isoform, which would degrade mouse cationic trypsinogen. So there is a mouse which was generated also in Miklós's lab, where they deleted this isoform and looked at pancreatitis severity. So what we found in the first case was that chymotrypsin C did have a protective function when we restored this isoform and challenged these animals with cerulean injection. We've seen a less severe pancreatitis than in the case of the Black 6 mouse. And once the chymotrypsin B1 isoform was deleted, these animals developed more severe pancreatitis compared to the Black 6 mouse. So then these two models actually proved the importance or the protective role of chymotrypsin in the in vivo setting. And lastly, I wanted to mention trypsin inhibition as well, because a lot of people worked on this angle. So first, what SPINK1 does is to delay autoactivation, because during autoactivation, the spontaneously generated trypsin, active trypsin, would catalyze further trypsinogen-trypsin conversions. And if there's SPINK1 present, then this would inhibit the active trypsin. So it cannot do this catalysis further on. But at times, these SPINK1 levels got depleted, and then trypsin autoactivation can proceed. And so when people looked at this in the in vivo setting, they saw that when they knocked out SPINK3, which at that time was called SPINK3, it's a mouse SPINK1, they saw a very interesting phenotype that homozygous mice became runted soon after birth and died, but they did not detect any phenotype in the heterozygous state, not even when they challenged the mouse with cerulean. So then Roger Little and his group took a different approach, and what they did is to introduce the rat SPINK gene into the mouse. So they generated a transgenic animal, and then they looked at acute and chronic pancreatitis severity. And since they got some positive phenotype, they crossed this mouse with a previously lethal SPINK3 knockout homozygous animals. And this is what they got. On the left, you can see the transgenic mouse, which had a rat SPINK1 gene. And this is the chronic pancreatitis experiment. They did see that SPINK1 was protective in the case. And on the right side, you can see that what happened when they crossed this mouse with the SPINK3 homozygous mouse, which would be lethal alone. And they did see that this transgenic addition could rescue the lethal phenotype. So again, this has been proved in the in vivo level that SPINK1 is something we should look at because it has a very important protective role. So I'd like to close my talk with what can we do next. And earlier this morning, we've heard that attention is shifting from proteases to cytokines, but I'd like to emphasize the importance of proteases, and then we still need to focus on those, and we still need to target. And one way to do is to somehow enhance chymotrypsin levels in the pancreas, and this could be done by a genetic approach, and then the other one would be targeting trypsin inhibition by developing drugs. And this could be, so this is kind of already been tested and it's on the way. And there's going to be a very interesting poster on from Jeff Way, Wyss Institute tomorrow, where they develop a SPINK1 trypsin inhibitor and they test in mouse models of pancreatitis. So thank you very much for the attention.
Thank you so much. That was excellent.
Gives me a great pleasure to introduce our next speaker, a person who's well known to members of the APA, Julia Meyerly. Julia is the department chair at the University of Munich. And as an overview, Julia is one of the few people I know in our line of work that can do everything and does it well. As you'll see, she's a basic scientist, but also a clinical scientist, and has been part of some very important clinical publications. She studies pancreatitis as well as pancreatic cancer. And for the last couple of years, she's been an administrator, which she may say is one of her most difficult jobs and challenging. So Julia, we look forward to the discussion and your discussion of immunity and immune therapy in pancreatic cancer. Thank you.
Fred, thanks a lot for this very nice introduction. I probably don't deserve, but so when I saw the title of my talk, I was thinking in two lines. A, is this because our secretary of the APA is a translational scientist and wants to see translational science on the program, or is this because of Aida being president this year and she wants to pick on our brains and wants to actually take the knowledge out of this room to Pfizer? So, but then, okay, I thought that's probably a little bit narrow-minded. And I then understood why we are talking about this subject. And this is if you look on the FDA homepage and you look for look at the Animal Model Qualification Program called AMQP as a drug developmental tool, I understood that FDA is ready to accept novel therapeutic approaches if we have well-designed animal models. And the aim of my talk today is to show you where are the obstacles in defining relevant animal models. And as I'm in the mid of my career, I probably look at this topic from a different point of view compared to Ashok. I don't see it as a disastrous endeavor, but I see it as a way with many options. So each animal model used needs to exhibit key characteristics of the human disease or condition of interest, and each animal model used is appropriate for use with the investigational drug. So it's written there, and I think that is what we have to keep in mind if we think about immunological models or models we use for our studies. So you all know pancreatitis either has a mild course, and that's 80%, and the mortality is roughly 1%. It's a short stay, hospital stay, and rarely complications occur. And then you have the other disease, I would call it, and there you have a 15 to 30% mortality. You have a systemic inflammatory response syndrome, you have organ failure, you have infected necrosis, and a huge mortality. And I think all clinicians in the room will agree on that these are two different diseases, and they need to be looked at differently. And it's not that if you treat the mild course wrongly, it will turn into a severe course. Those are, for whatever not understood reasons, two different diseases. So Fred and Marcus published back in 2013 a review paper in gastroenterology on pancreatitis models. And I don't want to get into detail here because Ashok did, but I want to point out to is when they were talking about there's no laser pointer, okay. So you have to look on the right side on top on the square box 2. If it comes to inflammatory reaction and response in this paper describing up-to-date methods at that time, the only thing mentioned is the NF-kappa B pathway. That's all. There is not a single leukocyte mentioned. So, and that was the time when I and Matthias, who's in the room, and I think this talk is a talk clearly which we should give together, because Matthias has spent his last 15 years on elucidating the immune response in acute pancreatitis. So that was the time when we were thinking about models. So, and if you want to know, if you think about what the models you should use, you say, and that's very similar to FDA, it should mimic the disease mechanism of pancreatitis. So it's either outflow obstruction, like in biliary pancreatitis, it's acinar cell toxicity, like alcohol or smoking, it's intracellular protease activation or a genetic predisposition leading to intracellular protease activation. And yes, there's the duct cell. So it should mimic the disease course of pancreatitis. So it's a mild course without a significant SIRS and without organ failure versus a severe course, including mortality, recurrent pancreatitis versus chronic pancreatitis. There should be necrosis formation, and there should also be bacterial translocation, because those are all features pathognomonic to the disease we are all interested in. It should mimic disease symptoms of pancreatitis. So there should be pain. If we report in guidelines that 40% of our patients or 80% of our patients present with pain, it should mimic pain. Pain should be, we should be able to study it. There should be exocrine and endocrine insufficiency. There should be bacterial translocation. And as Ashok pointed out, it should be amenable to therapeutic approaches or interventions. There should be options for genetic manipulation, should be cost efficient, and there should be research agents available. So, and if you look through that, then you will recognize that all models fall short. And this is why most reviewers, including the FDA and journals, will ask for a second or even third model, because you have to combine the data. You can't just rely on a single model. So let's start with the most common model we all use. That's cerulean-induced pancreatitis. Supramaximal secretagogue stimulation with a CCK antagonist, mild edematous pancreatitis, no disease-associated mortality, development of mild SIRS characterized by some increase of IL-6 or IL-8, nearly no T-cell activation, restitutio ad integrum the moment you stop cerulean, recurrent acute pancreatitis possible, might be nice, repetitive stimulation leading to something which you might call chronic for a short period, epigenetic changes, and ADM formation. So there seems to be some memory. Chronic pancreatitis if continuously injected, but no exocrine or endocrine failure, and the pain is minimal. 2,705 PubMed listed references on this model. And at best, it resembles a mild course of pancreatitis. So let's get back to what nice review by Pramod Garg. You heard him earlier today. So if we have pancreatic inflammation, and if we want to understand the mechanism on inflammatory response, organ failure, infected necrosis, and mortality, then we have to understand there's tissue injury, and then you have a systemic inflammation, which drives early organ failure and early mortality, and you have infection, especially in infected necrosis, driving late secondary organ failure and late mortality. So if this is the disease you want to study, your model needs to mimic that. And you need to study the orchestra. You need to study innate immunity and adaptive immunity. And you see that a number of people have actually done that in previous years, and we have gathered information, which I will shortly outline to you. So what do we need? What do we know, and what do we need to know about our models? Well, they need to have a systemic inflammatory response, and they should probably also have a compensatory anti-inflammatory response, or SARS. And for a long time, we believed that they follow a subsequential part, and there are lots of cytokines being increased. Nowadays, and I outline that to you in a moment, we probably believe that that runs in parallel, but maybe that doesn't matter as long as you can study it in your disease. So the first model we tried to use to study this was taurocolate injection in the pancreatic duct in mice. So why did we do that? Because it gives you a huge tissue injury, and that gives you a systemic inflammatory response. But let's be honest, if you use just some kind of toxic agent and inject it in the pancreas, you destroy the pancreas, but that has nothing to do with pancreatitis. And the second problem in this model is you have to ligate the bile duct. So it can never be a chronic model, because what you induce over time is cholangitis. So the mortality varies between 0 and 80%, depending on the concentration of taurocolate you use. But you develop an extensive sursine curse. And that can be seen here. You get an increase in amylase, so it's pancreatitis. Well, you do get mortality, and you see that there's an inflammatory reaction just if you look at that the size of the thymus and the spleen is decreasing over time, because all the inflammatory cells get apoptotic. Simple sign of a strong systemic inflammatory response. So the next question is, can these models be used, or is it amenable to, for therapeutic implication? And that's shown here. You can actually increase survival of animals treated not prophylactically, but therapeutically with an inhibitor. You don't have to care about the inhibitor. In this case, it was PNM allostase and pancreatic allostase. A combined inhibitor, what you can do, you can shift mortality. So it's amenable to treatment. It's a pro. However, thinking about the model and working with it for quite some years, we recognized it doesn't really meet our expectations or needs. And then we thought, what is the model? What is the pathogenesis of acute pancreatitis? We need duct blockage, because that's what we observe in biliary pancreatitis. And we also need, as the second hallmark, intracellular protease activation. Yes, I agree. Intracellular protease activation is not induced by CCK in humans, but it somehow occurs. Maybe calcium, different mechanism, it does occur. So let's use these two disease mechanisms and induce pancreatitis. So we ligated the pancreatic duct, and after two days after surgery, the animals get a single injection of cerulean. And that actually starts pancreatitis, and you see you have a rise in amylase, you have a rise in IL-6, you have huge areas of necrosis. You can see that on the histology, and then later on that turns into fibrosis. So you have acute and chronic. Drawback, you've ligated the pancreatic duct, it will never resolve because the ligation is capped. But you can study the inflammatory response, and you can also study pain. So you see the distance traveled as one of the hallmarks of pancreatitis in these animals. You can clearly see that in a duct ligation model, they travel shorter, they experience pain. You can measure that. You can also measure the exocrine insufficiency, here outlined here as elastase in the feces, and you can even quantify that from a different publication by MRI, the secretion into the duodenum. So you can measure the hallmarks of pancreatitis. And again, this model is amenable to treatment. So in this situation, it's a C5a inhibitor, and that actually reduces fibrosis formation if you do trichrome staining, collagen 1 or alpha SMA staining. So might be a model which can be used. And this is why we've used it for a number of experiments, and I'm showing you one here that is from Matthias. And the reason why I picked that is that it is a very recent publication. And what he did here, he was using animals where you can deplete regulatory T cells, and you get a type 2 immune response, and you get a decrease in fibrosis formation. And the reason why I'm showing you this again is that you can measure clinical relevant outcomes, like the weight of the animals over time. So what you see, if you deplete FOXP3 positive Tregs, you get a type 2 immune response. You get alternatively activated macrophages. They activate pancreatic stellate cells, and you get fibrosis. So that is something which we can learn and understand from such a model, and that might help us to find a treatment. Another thing which you can do in these models, and the reason why I'm showing you this slide is because you can compare the severe model to the mild model. So you see in severe pancreatitis, so 3 days post-ligation, you see a lot of macrophages in the middle. Well, if you do 8 hours of cerulean injection, you see very little macrophages, hardly more than in the untreated controls. So if you want to study the immune reaction, the cerulean model is no use. What we also learned from this model is that macrophages do play a major role, and they can actually be involved in trypsin activation as a secondary effect, as a self-feeding wheel, and also cathepsin B dependent, as you can see here. So I don't want to go into detail, but again, that is a very nice study from Matthias, where he showed that trypsinogen engulfed in macrophages activated by cathepsin B in endosomes leads to the activation of NF-kappa B secretion of pro-inflammatory cytokines, which will then activate macrophages. And again, that will lead either to resolution of the inflammation or to fibrosis. So there are the regulators, and there's the link from the trypsin models or genetically engineered protease models to the immune response. So if you delete, and that is something which is even more important, if you want to not only look at the pancreas, but to secondary organ failure. And none of our patients dies from pancreatitis. They die from pulmonary failure, they die from kidney failure, or infected necrosis and sepsis. Then what you can see here is a recent publication in Frontiers of Immunology, also from Matthias' group, where he showed that if you deplete monocytes, then you will find cells sticking in that can explain organ dysfunction, because those cells stick in the lung and prevent breathing, proper breathing. So again, what I would like to show you here, you can use oxygen saturation in mice to actually study organ failure. And that is what we study in human, and this is what we can compare. So but what we have to understand is we want to treat. And this is what comes here. So in these very severe model, you see that SIRS and CARs run in parallel, too complicated for a short talk. But the macrophages actually cause the SIRS, the T cells regulate the CARs, and these functions via different cytokines and eventually leads to fibrosis. Can we prevent that? Yes, we can. If we use a small molecule inhibitor, also therapeutically inhibiting the inflammasome, one of the key players of the immune reactions, mainly in macrophages and monocytes, we can actually ameliorate not only pancreatic damage, but also lung damage. Simple thing, could be used in a clinical trial, and the model might be accepted by FDA. So that is the last data slide I'd like to show you. And this is again on regulatory T cells and is a paper under revision. And that shows you for the first time, again, a very important pathognomonic features of pancreatitis. And that is the translocation of bacteria to the inflamed tissue. And what you can see here that in a very severe model, so same model I showed to you, there's an increase in bacteria, and that correlates to the number of regulatory T cells. So if you deplete the T cells, then the intestinal barrier is lost. You have translocation, and again, the effect of depletion of regulatory T cells is as strong as if you use antibiotics treating these animals. So that again shows us that we should pick ideas from IBD and other rheumatology and other inflammatory parameters, because modulating the immune response can be as powerful as using antibiotics. So to sum up, inflammation is the driver of mortality in pancreatitis, and therefore we need to study it. Models to study pancreatitis should mimic the disease spectrum, including the inflammatory response. Keep in mind, a single model might not picture all aspects. Clinical trials testing novel compounds in men require enormous funding. Thus, in balancing the risk before taking a compound to the market, we need to thoroughly question our results from animal models and also question the relevance of our models. Please have a look at the FDA Animal Model Qualification Program to ensure that we will find a therapy for pancreatitis. Thanks for your attention.
Thank you so much. As a reminder from the beginning of the session, our last speaker will not be able to join us. So we're gonna open it up now for discussion. Very provocative questions, talks this afternoon. Yes.
Hi, I'm Michelle Cooley from the University of Wisconsin. Thank you all for a very interesting discussion. I think you've really encapsulated all of the frustrations that we as basic scientists have working in this finicky organ. So it goes without saying acinar cells are notoriously difficult to work with, but one model we are really lacking as a field are satisfactory cultured cell lines and 3D culture and organoids. Of course, these models have their own pitfalls, but they are still useful tools. So I was wondering if any of you could comment on where we are in creating better cell lines and 3D culture models for us to work with.
Well, I think you have to discriminate between pancreatitis and pancreatic cancer. I think there are models available for pancreatic cancer, even there are organoids, and there are by now organoid banks you can use and primary cultured cells from endogenous pancreatic cancer models and also humans. So that's not really a problem, I guess. With respect to pancreatitis, I totally agree. You can only work on freshly isolated pancreatic acinar cells. And I mean, there are a couple of protocols where you can cultivate them for, say, 48 hours. But everything you do after that, you're no longer studying an acinar cell. I don't see any real possibility to change that, because the reason why it's not that you can keep the cells alive, that's not the problem. but they just lose their behavior and they de-differentiate mainly to endocrine cells. And I don't think that even if you would use a culture media substituted with growth factors like noggin or a stem cell media, would change that. So in this, the only way, what you can do is you can try to work with the AR42J cells. That doesn't help much because those you have to differentiate it with prednisolone, otherwise it's not gonna, or dexamethasone, otherwise it's not gonna work. So we are lacking those models, and that also prevents good co-culture models. But I don't see a good solution to that.
Okay, the other side. Thank you for this very exciting session. And I think one thing I was really missing, you have to frame the question a little differently. It depends what you want to study, because there's disease initiation and disease outcomes. As you know, Vijay Singh really nicely separates these two things. By the way, neither of you mentioned Vijay Singh's model, which are outstanding for disease outcomes, and study the exact problems that you raised.
Say that again. What did we mention for disease outcome?
Vijay's models.
VJs.
So for instance, if you look at disease initiation, then you can make the argument that the cerulean model or the arginine model is not relevant. So for those, you would want to use the genetic models, obviously, because that may be more relevant. But if you look at immunology or some other outcomes, then arginine model can be perfect because you can do a lot of damage and you can have a severe outcome, and then you can study the outcomes. I think you always have to define what the purpose of your study is in the context of the particular model.
But at least to the questions we were addressing, the arginine models always had the problem that either the animals die over at a very short period and then never develop chronic changes to the pancreas. So yes, I agree, you could study the inflammatory response early on, but you don't have the long-term possibility to look for tissue damage and see whether there's the tissue damage in itself will prolong inflammation. But as an acute model, you can certainly use it. It's in our hands a little
but again,
bit.
not to study initiation, because arginine doesn't initiate pancreatitis in humans, right?
No, the early inflammatory response, if you want to say so.
But I think for this session, to me, the real question is, how do we use these models to cure pancreatitis? Not to study, obviously we need mechanisms, you know, I mean, I'm a PhD and mechanism is our life, but the goal is really, how does these models really help us? Or what we have achieved with these models, where we can say, you know, we use this model, we tested this drug, and now we're going to take that to patients and we're going to do a trial. And that's where we need to, at least for this session, that I thought that was our focus. And I still don't see that how, whether it's arginine model or, you know, the models you and Matthias has beautifully described, what have we accomplished? Other than finding out what kind of inflammation is involved in that. Obviously, that's prerequisite, and I'm not underestimating by any stretch. The question is where we are going with that.
So congratulations, this was really, really a very exciting, fascinating session. I congratulate to all speakers. After Ashok's speak, I was thinking to leave the room because nothing else can come. But after the two ladies talk, I am no more convinced that we definitely need the animal models. Actually, my question would be very specific also on the end also to Julia. One of them is, no, I am getting really sure that we cannot mimic human situation, that's for sure. But we can get mechanistic insights into pancreatitis, and this is what animal models for. I am not convinced about the therapy part, because the patients die in sepsis and the patients are in organ failure and so on, and we don't have a good model. But the mechanistic insights, this is what we need for. So for Andy, my question would be actually about the possible therapy like a gene editing part in the pancreas. So you showed that like also the CTRC and SPINK1, they are really beneficial. Of course, the trypsin part is bad. So I saw the autoactivation part, which very well shown it, how the autoactivation of trypsinogen related to the disease progression. So my question, what would happen if we either downregulate so would cause a loss of function mutation part on the trypsin side, or maybe to make an overexpression, for example, in the animal, either the SPINK or CTRC. And my second question would be about whether also we can see in human how they are together happening, even the patient has a CTRC mutation plus maybe they have a SPINK mutation or whatsoever. My second part would be to Julia about this immune mechanism. It's crucially important because the patients die actually due to the incorrect immune response and the infections and so on. So what about like combination like biological therapies, antibiotics, steroid or whatever in this immune response? Because the other issue is that it seems that somehow, and also in pancreatic cancer, the immune therapies and so on, the pancreas behave differently. So in some cases, like in IBD, you can find beneficial effects or working in the issues. Here you can't. In melanoma, you may see, you know, in immune therapy benefit, pancreas not. What is different in the pancreas?
Thank you, Peter, for your question. And yeah, this is an interesting concept of gene editing or bringing up gene editing. And I haven't really thought about in the context of trypsin autoactivation and by depleting trypsin activation. The problem is that the mouse have or has 20 trypsinogen isoforms. Luckily, some of them are pseudogenes or relic genes. So basically, there are 4 which are expressed the highest level. So I think once you start to modify, there might be an other isoform which might kick in and then take over the role of the T7, which is the cationic trypsinogen. I think what we should probably target first is enhancing chymotrypsin levels. That could be an easier approach. We already have sort of the proof of concept with this chymotrypsin mutant mouse. They could not really serve as maybe the chymotrypsin B1 deleted mouse. It can serve as a preclinical model, but the other one where we restored chymotrypsin C function, that could serve as a proof of concept. So we could try to enhance chymotrypsin levels. And yeah, I think that should be one of the next step, and we should go down this road. We should further explore, definitely.
Peter, simple answer to a complicated question. If I treat animals with steroids or whatever, it's not going to be a gastro paper. And I need a funder, somebody funding my research. So basically, I think the models are there to study aspects of pancreatitis, even treatment-wise. But then you need a close collaboration with industry with respect to the FDA models being approved, and do these experiments in an academic environment where we have to justify the money we spend by our research questions and are rated for that. I can't see that the German research agency will fund animal models treated with steroids or heparin or a piggybacking drug compound. So we need to closely collaborate with industry in there, and then that should be possible. And we need to advertise ourselves to industry and tell them we are able to do that.
I think
So,
they were waiting before me. Okay, thank you very much. So it's Minoti from Sydney. I enjoyed the talks very much. One of the things that we completely ignore when we talk about pancreatitis is the endocrine aspect, and diabetes is increasingly recognized even for acute pancreatitis. So I was wondering whether any of the models that we've described, we are the same. We do alcohol-related pancreatitis and ignore the islets. So this is just putting it out there. I think maybe we need to start thinking more about the exocrine-endocrine axis as well.
So Matthias' model does give you a impaired glucose homeostasis. I wouldn't call it diabetes because there's more than, so the reserve is there, but they're hyperglycemic in the early phase of pancreatitis, and you can see the weight loss is also in the later phases due to an insulin disbalance, put it that way.
Thank you. These talks sort of tell about the limitations of these models, as well as, I think, more importantly, the opportunities. You touched upon organoids, for example. There are papers of recent, even a year ago, about organoids that retain early acinar markers. There are slice cultures of pancreas. Herb Gassano is here, for example, and he's really sort of published on that model. I guess the opportunities can be exploited further. I know, for example, I attended a week-long course for imaging in Maine because I just wanted to learn about confocal imaging a while back. Similarly, I wonder whether there could be a crash course to teach our trainees from established investigators, the basics of induction of the models that we at least agree upon, and secondly, assays for them. And related to that, in that course or otherwise, the FDA really looks at safety as much as efficacy, and you could argue more safety than efficacy. And when you read their non-binding recommendations, they often ask for one non-rodent model in addition to a rodent model as proof of principle. So one should consider that there's old literature in non-rodents as well. So I just thought I'd comment and see if the panel had comments about that.
To be honest, I was thinking the same line, and I thought, should I talk about ferrets? Should I talk about mini pigs? Should I talk about many of these other models? And then in the interest of time, I decided I'm not an expert in there, so I decided not to, but you're absolutely right. There are other models which we need to explore and need to include in our research. With respect to teaching, that is something we try to do at the German Pancreatic Club. So there's a hands-on meeting up front in the labs. One year it's imaging, next year it's cancer models, year after it's pancreatitis. So this is what we try to do to actually teach people on methods, because they are very important. And I remind you, there's also these wonderful Pancreatopedia, where we all wrote chapters on different methods John Williams started. And I think it's very helpful for people who start, and we might at a certain age forget about those options and valuable information.
So Sohail, I think FDA does understand that for some of these diseases we study, and particularly pancreatic cancer, the models to study are really rodents. Actually, it's mostly mice, not even rats, right? So I think that part is okay. What FDA really requires, and rightly so, is when you propose a trial, you have to have toxicity studies. And those toxicity studies have to be in non-rodent models, whether you dogs, monkeys, whatever. So you have to have a rodent model plus a non-rodent model. Like in our case, when we are doing Menlite trials, we had toxicity studies in rats and dogs, and that was acceptable.
Really enjoyed the session. This is Vikas Tudeja from UAB. So just want to make a couple comments. Number one is that for example, in L-arginine model, even though after the one episode, we do see a lot of recovery, what we really don't know is that are there any chronic changes even after one episode? We have not studied that. But of course, once you repeatedly give them injury, it does lead to chronic changes which are really persistent. The second comment that I have is, I think the problem is not only of the model, but also of the modeling. Because if we even have a severe model like L-arginine, but if we give the medications in a prophylactic fashion, we are not recapitulating the biology where the patient presents 48 hours or 24 hours after the things have started. So I think it's very important that even though we may not have the perfect models, but at least we try to simulate the disease process, that we are starting the treatment at the peak of injury or even when the injury has really set in. So I would love to hear any comments.
So this is why I only showed you data on not prophylactic, but real treatment. And the treatment was only commenced after the peak of the inflammatory response had already occurred, so 48 hours.
I have a question to ask Professor Julian. I'm from Heidelberg University of Germany, used to visit your laboratory and learn how to generate organoids. Since you talk about the acinar cells, we cannot continue generate the acinar cells for over 48 hours. And then they will, because they will not be called acinar cells, but which reminds me that organoids, once we generate the organoids from the tissue and we culture them in the conditioned medium or culture medium, which they are also be differentiate and also lose their heterogeneity. So my question about the practical usage is that when is the time for us to better use this kind of model of organoid? When should we use it? Because we use it in a really early stage, we don't have enough cells to do the experiments. But if we use in the relatively late stage, they may already not represent the human or that patient.
But now you're talking about pancreatic cancer organoids, or?
Yes. Yes.
Yeah, well, I mean, the pancreatic cancer organoids, to me, the moment we use them for therapeutic studies is after the forced passaging, and usually we try to freeze them and thaw them again and reculture them, and this is when we use them and we classify them as a stable, say, cell line or organoid, which we then compare to another. I don't think that, at least I don't know very good data studying the precise time point and the change. And there are some data from your group where you studied the changes over time, but I've only seen them as an abstract or as a poster at one of the conferences. But I can't give you a good answer to that. Maybe is there somebody more knowledgeable in the room who could address that question?
Thank you very much.
Thanks, Sylvia. Aida Haptizian, Stanford and Pfizer. So I'll make a comment. And the comment is that I commend you all, because what we are highlighting is a gap in our knowledge in our field, which is the one that brings close actually what this whole symposium is, how to bring the bench close to the bedside and the bedside close to the bench. Because the animal models do have a place, but the question is how to position them. So if I use also my experience in IBD, not every model is actually modeled for the specific, whether it's the pathway, whether it's the asset, whether it's the therapy or diagnostic, one has to position it in a different way. I think Miklas's point is a very good one, because genetics, for example, that comes from the human genetics, and one takes it to the bench, for example, because there is causality. And the same with Minotti's animal models of alcohol with Steve Pandol, etc. Because I think it is like, what question are we asking and where do we position our models? Which means also we need to understand the human disease, the natural course of that's also where we are lacking. Because if we can understand how you get from inflammation to necrosis, or how you initiate that, etc., we can model it better, because those animal models do work to a certain extent, but not to the whole extent. So I think we are using the animal model as if they are going to answer all our questions. So I'm just bringing this to us in APA is one of the things we said this morning. There was a takeaway message, what we will do next. I think this would be a good opportunity for us to come closer to understand the natural course of the disease and how to position our animal models to answer the important questions that we are trying to address. Thank you.
Thank you so much. I also like to echo Sohail's comment about a workshop for scientists, especially bench scientists, on models of pancreatitis. I think the pancreatic cancer field has done that very efficiently. I think in the pancreatitis world, we might want to do something similar. So I encourage those stakeholders of organizations that might be able to sponsor, foster, or help organize this to consider it. I think we're good at highlighting a lot of problems today in this session. And like I echo what Aida says, position those mouse models for the questions that we want to ask in the lab that can then answer a small question for our clinical colleagues. It was a pleasure. Thank you all for joining us and giving some excellent talks, and everybody for the discussions that we had. Since there are no more questions, we can close this session, and I think we're going on a break.